Hi, I'm Dr. Ted of Jefferson Orthopedics, and this is Fracture Friday. The general idea is that we go over topics that I find interesting in orthopedics right now. It could be a fracture, it could be another topic that has to do with orthopedics. This happens to be a non-fracture topic this week. It's about unstable or dislocating total hips. Now, total hips are interesting. There's been a transition from what was traditionally a posterior approach procedure. In other words, we made the incision through the back of the hip to more of what's called an anterior lateral approach, where we make the approach through the front of the hip now. Anterior is in the front of the human body, posterior is the back. So we originally had the posterior approach, which was through the back, through kind of like the gluteus musculature or through the butt, kind of. And now it's more anterior in the front of the hip. Okay, so this was a posterior approach. This patient had a posterior approach to a total hip replacement that was done in 2011. They presented to the hospital with repeated dislocations. She dislocated once on last Tuesday, then again on Thursday, then again on Sunday. I wasn't on call for any of those, but she presented again on Tuesday with the fourth dislocation. So what we decided to do was to admit her to the hospital after reducing the hip in the ER. So we should probably talk about that first. What originally happens if you have a hip replacement and it's never dislocated, and the discussion of the dislocating total hip makes your heart sink to places you'd rather it didn't. What happens if your hip pops out of joint is you'll go to the ER and it causes quite a bit of pain. So the first line treatment, the original goal of treatment for the medical personnel, is to get the hip back in. Okay. In this particular patient, the emergency department tried to put the hip back in and it didn't work. So they called me and I came in and with the help of the ER doctor and more conscious sedation, we were able to get the hip back in. Okay, so now that that's been accomplished, the patient it will be much more comfortable for the patient to be in the hospital, and they won't be in quite as much pain. But we have to, now that the hip has popped out 4 times in the matter of a week, we have to make the hip that was for a long period of time, really, not in total hip terms, but in calendar terms, from 2011 to 2017 the hip was stable. Now all of a sudden it's not. Okay, so we have to make sure that we fix it and make it stable. So the terms we use is this is a unstable hip prosthesis, meaning that it's unstable in the terms of the hip being located. The femoral head, the ball of the stem, is in the cup of the acetabulum. So I can show you this x-ray, which is where the hip is out of joint. Okay, and then there's this other x-ray right here. This is where we put the ball back in. So this is a located hip, and the previous x-ray was where it was dislocated. Okay, but this hip is not what I would call stable. So what is done is called a constrained liner, meaning that when you look at these x-rays, we'll focus on this x-ray here after the reduction. You have a femoral component, and you have the femoral head, which is this ball, and then there's a piece of plastic that sits inside this metal cup here that's in the pelvis. You have that metal cup in the pelvis when you're looking at this x-ray. So that metal cup has a plastic liner that sits inside that. So that metal ball articulates with that plastic liner. So that's what makes a total hip. So what's happening is that metal ball is sliding out of that plastic liner. So we have a liner that's constrained. In other words, it grabs onto the ball and won't let it come out. It has a metal collar that goes over it. So when you look at these x-rays, which is post-op after the revision total hip, you see this metal ring that wasn't floating there before. And it only looks like it's floating there is because it's driven into, it locks into the plastic. But on x-ray, and if you're not used to looking at x-rays, I'll go over this a little bit. On x-ray, we can't see the plastic. Like if you've had a total joint, it looks like everything's made out of metal and it just floats like it's apart. But there's no way in the human body for parts to float apart. They have to actually touch because of gravity and the way the physical world works. So the x-ray beam goes straight through the plastic, so we can't see it. It's like it's invisible. It's there, but on x-ray it's not there. So that was that's why it looks like this metal ring is floating there in space. So this would take quite a bit of force for it to ever come out again, and it should never come out again, which has taken an unstable hip and made it stable. And I think that's basically all I have to say about that. Hey, Dr. Ted again. Don't forget to like and subscribe to our page. And by the way, If you'd like, please make comments at the bottom. I'll try to answer any comments that you may or may not have at the bottom as soon as I can get to it. And if you have any topics you'd like to hear about in the future, maybe you have a family member that sustained an injury, maybe you had an injury and you'd like to learn more about the general principles behind this treatment of said injury or said problem, then send me a message and I'll try to do a video about that in the future. Thanks for watching.